Morning.
Yeah. Morning. Yes. So, and good morning, and thank you for being here for our ground rounds today. I'm Pamela, one of the cardiology research fellows. I'm pleased to introduce to you our speaker today, Dr. Joshua Joseph, who will be talking to us about equity in cardiometabolic prevention. Today's lecture is part of the Natalie and Jack Congdon Visiting Scholar in Cardiology lecture series. First, a brief history about the lectureship. In 2010, Natalie and Jack Congdon established the Natalie and Jack Congdon Visiting Scholar in Cardiology, which enables the VCU Health Pauley Heart Center attract a number of talented cardiologists. After his service in the Army, Jack helped build the family tracking businesses of the Old Dominion Freight Line and Old Dominion Truck Leasing. Jack was a proud supporter of the Macy Cancer Center and the Pauley Heart Center. Jack and Natalie passed away about 10 years ago. They had 3 children, and their son John continues to support Pauley Heart Center as a donor and advisory board member. Our guest speaker today is Dr. Joshua J. Joseph, an associate professor of internal medicine with tenure and endowed professor for research in internal medicine in the Division of Endocrinology, Diabetes and Metabolism at the Ohio State University Wexner Medical Center, OSUWMC. He's a co-chair of the OSUWMC Healthy Communities Obesity and Nutrition Steering Committee and medical director of the OSWMC Healthy Community Center. Dr. Joseph's National Institute of Health, American Heart Association, Agency of Healthcare Research and Quality, Robert Wood Johnson Foundation, and the United States Department of Defense funded research focuses on advancing prevention and treatment of obesity, diabetes, and cardiovascular diseases through a health equity lens with 4 pillars. 1, examining the role of stress hormones in cardiometabolic disease. 2, health system to community innovations. 3, community-based participatory research. And 4, quality improvement science. Dr. Joseph treats patients with diabetes and cardiovascular disease at a community-based clinic. Nationally, he's chair of the Endocrine Society Clinical Affairs Core Committee, chair-elect of the American Heart Association Council on Lifestyle and Cardiometabolic Health Diabetes Committee, and president-elect of the Central Ohio American Heart Association Board. He has been recognized for his science, community engagement, and clinical impact with several awards, including election to Alpha Omega Alpha, National Minority Quality Forum 40 Under 40, and the American Society for Clinical Investigation. We are grateful for Dr. Joseph's expertise on this topic and look forward to learning from him. At the end of the lecture, we'll leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. And we are pleased to offer CME and MOC credit for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and the end of this presentation to 804-625-4041. For questions, please contact Shannon Winston. I will now turn it over to Dr. Joseph.
Perfect. Well, Pamela, thank you for that very kind introduction. You know, sometimes you hear those introductions like, well, who are they talking about there? That's not me. I'm Joshua from Columbus, Ohio. So pleasure to be with everyone today. And we're going to talk about cardiometabolic prevention. Let's see. It's one of these. Give me 1 second. Oh, there we go. These are my relevant grant disclosures. You already heard my bio. So our objectives today are to discuss inequities in cardiometabolic disease, discuss the role of academic, community, government partnerships and implementation research, and really give real-world examples of implementation interventions to advance cardiometabolic health equity. So why cardiometabolic disease? And at dinner, we talked a little bit about some parts of this, but really it starts with my grandmother. So my grandmother is the person who taught me my ABCs and my 1, 2, 3s while my parents worked. She was a school teacher in Louisiana and came up when I was very young to Ohio. And, you know, I also, in addition to her teaching me my ABCs and 1, 2, 3s, remember herself giving herself insulin, right? She had diabetes. And so for many years, I would ask questions about insulin to her. I also remember the first time she left our house clutching her chest, right? And everyone in this room knows what that means. She was having a heart attack right there. We called 911. They sent her to the hospital. And over the course of about a week to 8 days at that point, people were in the hospital longer, she did really well and came back home. But unfortunately, a few months later, she went to the hospital and never came back home. And for me, that was really foundational in thinking about how can everyone, experience their grandmothers and grandfathers for longer periods of time, right? And really set my journey in many ways. I will say that, I don't know what my parents would dress me in, and my car looks a little bit different now than it did then. So a lot of our work focuses on Life's Essential 8 from the American Heart Association. These are 8 factors that we really know are critical in cardiovascular disease prevention, including blood pressure, blood cholesterol, blood glucose, body mass index, physical activity, diet, smoking, and sleep, what the American Heart Association terms Life's Essential 8. And when we look at these Life's Essential 8 factors, we've done a lot of work over time in many national cohorts to show that these factors are also critical in the prevention of diabetes, right? There's also work that they're critical in the prevention of cancer. So really, Life's Essential 8 are foundational to health, really irrespective of how you think about health and where you practice in the medical paradigm. What we know about Life's Essential 8 is that there are disparities by race and ethnicity. The score goes from 0 to 100. Each of those 8 factors gets a score of 0 to 100, and then they're averaged for a total score. When we look at those total scores in NHANES, what we see is that some racial ethnic groups have higher levels, nationally than others, and that's seen here on this slide. But what's really important is that a 6-point lower Life Essential 8 score is associated with a 16% higher risk of cardiovascular events. So when you see the difference of like 63 to 75, and that's a 12-point difference, just think about that difference in risk of cardiovascular events. We also know in diabetes that the incidence of diabetes has been declining since 2008 in non-Hispanic white and non-Hispanic Asian populations, where it's been flat to increasing in Hispanic and non-Hispanic Black populations. And we also know that there's differences in prevalence of diabetes across the United States, with Black Americans as well as, Black American populations having the highest rates of diabetes in the United States. And then when we think about disparities in not only the prevalence of diabetes and the incidence of diabetes, there's also differences and disparities in utilization of medications for diabetes. For instance, on the right side of the slide, when we talk about our GLP-1 receptor agonists, medications that not only improve diabetes, but lower weight, as well as lower cardiovascular events, you can see that compared with white individuals, Asian, Black, and Hispanic populations have lower utilization of GLP-1 receptor agonists, as well as individuals with lower median incomes. So by race and ethnicity and socioeconomic status. So where does this get us? When we look at the prevalence of diabetes control, we know that only 1 in 2 individuals meet an A1C target of less than 7%. And when we look at all 3 risk factors combined, the ABCs of diabetes, A1C, blood pressure, and cholesterol, only 1 in 5 individuals across our great country meet the targets for all those 3. And those are really critical in cardiovascular disease prevention. And we know that there are disparities minoritized, rural, and lower socioeconomic status populations with even lower rates in those groups. When we look at Black-white mortality rate ratios, there are also large disparities there. Across the US, there's a 2.2-fold diabetes mortality ratio, but it really spans different cities and different areas. It's heterogeneous, with DC having a 7-fold ratio, and Philadelphia, for instance, having a 1.9-fold ratio. And there are also kind of rural-urban disparities, where there's a 2-fold death disparity in rural areas. And you can see that Black rural populations have the highest diabetes mortality of any racial ethnic group. And this was work done by Emma Faloco, who just last night texted me. She'll be going to Beth Israel for a cardiology fellowship. And so super proud of her. And so what are the roots of some of the diabetes inequities that I showed? Well, we know that there are downstream health outcomes. This is the lake in the picture, things like asthma, heart disease, diabetes. We know that there are midstream determinants of these factors, things like food insecurity, unsafe and overcrowded housing, poor access to high quality healthcare, income inequality, unemployment, etc. But at the top of the mountain, there are things like racism, discrimination, and poverty, which really are the upstream determinants that for many populations drive the disparities that we see. If you want to learn more about some of the disparities, because today we're going to talk a lot about solutions, but if you want to learn more about the disparities, I encourage you to check out this paper, Casting a Health Equity Lens on Endocrinology and Diabetes, with Dr. Sharita Hill-Golden and the late Dr. Felicia Hill-Briggs, as well as a second paper, Eradicating Racism and Endocrine Society Policy Perspective, that we wrote. In both these papers, we go through the disparities as well as the historical nature to some of the disparities that we see in diabetes. Most recently, I wrote this paper, Advancing Equity in Diabetes Prevention, Treatment, and Outcomes. And this was the first chapter of a book on equity in cardiometabolic disease. So here we talked about not only disparities, but many of the solutions as well. And so what about, shifting gears a bit and thinking about solutions? So I lead the Accelerate Research Group, and it's advancing cardiometabolic health equity through translational research. We really have 4 pillars, as Pamela mentioned. We work on epidemiology, quality improvement, health system to community interventions, and community-based participatory research. Our roof is health equity, right? So everything we do is a focus around health equity. And our base is really academic, community, government, industry partnerships. And we really take a translational and team science-based approach. So we have work, all the way from T0 to T4. Today, I'll focus mostly on the T2 to T4 work that we're doing. And I always like to show the group. So we have 11 FTEs in the group. We have a number of graduate students and fellows that work with us. We got statisticians in the group. But these are the folks that do all the great work. I get to sit here and talk about it today, but it really is incredible leading such a fantastic group of folks. So what is health equity? I said health equity was our roof. Health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. And achieving this requires focus and ongoing societal efforts to address historical and contemporary injustices, overcome economic, social, and other obstacles to health and healthcare, and eliminate preventable health disparities. And that's the CDC definition for health equity. Well, what does that look like in pictures? And some people show a picture of the fence and the baseball game, right? You all seen that picture. I chose a different picture for this. So equality is these bikes, right? Everybody's got the same bike, right? The bike doesn't work at all for the little girl. It's too small for the dad, and it's too big for the son. I will always say that it's the perfect size for the mother, right? So if you're the mother in this example, the world is great, right? The world is great. It works. Whereas equity is having the right size bike for the right person, or the right size approach for the right person, right? And you can see here that the bike works for the little girl, works for the little boy, works for the father. Everyone has a bike that they can utilize. And so within thinking about equity, one of the things that we work on a lot is developing these partnerships. And these partnerships start with centering on community. This is from a conference that I co-lead at Ohio State, the Health Equity Through Diversity Action and Learning Conference. We had 300 participants this year in Columbus, Ohio. About 24 national speakers came in. And the day before, we had a session with 30 individuals, equal parts academia, community, government, and industry. And we had an illustrator and a writer. And this is from the illustrator. And what's important on this slide is just really the middle part, right? Is that we have to center on community, right? Community voices. And I know that you do hear this here at VCU. I heard all about it last night with your community advisory boards, et cetera. You also have to have shared governance, and real listening, right? And in the bottom right, our community members really believe that community should be on top of the partnership. Nothing for us without us, right? Or you've heard probably for us, by us, previously, as some of the very real pieces. And we like to create these environments where people can come together to have those conversations, right? From all the different sectors to make real change. So we also talk a lot about differences between outreach and engagement. So outreach is short-term. What can I do for you? Transactional. Whereas engagement is long-term. What can we accomplish together? And relational. And I've read a lot of the work here by like Vanessa Shepard and others. And I know y'all are big believers in community engagement, right? Great community engagement work. Where we love community outreach, but community engagement is really we're going to have to work together to make change into the future. And I talk a lot about breaking down the four walls of the healthcare system, right? I love healthcare. I love being a doc. I love wearing my white coat, right? Tuesday afternoons, I'm in clinic. It's wonderful. But I also love taking that white coat off and getting out in the community and talking to folks, having a conversation about health, and allowing them to open up and engage. As part of this, we believe that addressing social needs is also critical. So there's the social determinants of health, which we all know, right? But there's the social needs, and that's really the individual component of that. How do you experience food or transportation or utilities, right? And so we have a lot of models where we're able to screen, address social needs, gather data, engage with community, use that data and community engagement to advocate for policy, and ultimately invest in communities. And this is the AHRQ Community Pathways Hub model, which we utilize in Ohio. What's great about it is that after the social need is addressed, there's a payment from state Medicaid that goes back to the community care agencies. So it's really a sustainable model to address social needs. And in our group, we believe in the socio-ecological model. And so we start at the individual level, we go to the interpersonal level in our interventions, the organizational level, the community level. Like I said, we use a lot of Pathways Community Hub models to address social needs, and then public policy. And within this, we believe that every rung of this ladder is really, really important and really putting together multi-level interventions that ultimately impact public policy. And we do that by centering on equity with community engaged, diverse teams. So what do we do? Let's talk about some of the work that we do in the group now that we've kind of introduced you to who we are and what we do. So one of the projects from a quality improvement standpoint that I'm involved in is called CardioH. This is a quality improvement project at the state level funded by Medicaid in the state of Ohio. It spans across the state with over 30 to 40 practices that participate. We utilize the collective impact model to form this statewide diabetes quality improvement collaborative to improve diabetes outcomes and advance diabetes health equity. And like I say, we recruited, it was initially 20, it actually grew to about 35 practices across the state to participate in QI. And the goal was to reduce the percent of patients with an A1C greater than 9% from 25% to 21% over 2 years, so a 20% improvement. We use implementation strategies, including audit and feedback, peer-to-peer learning, QI coaching, and subject matter expert consultations. We align with the 6 Medicaid MCPs or managed care plans, and they added coverage for diabetes support and education. They removed the prior authorization requirements for continuous glucose monitors. They aligned quality limits on diabetes supplies, and they piloted home A1C testing. This was all made possible by our governor aligning to a single PBM in the state of Ohio. We would not have been able to do these things without that policy legislation that occurred. So you can think about us all in the room sitting down together to try to create change and improve diabetes. So what did we see with this? Well, we were doing this during the pandemic. So you see 2020, 2021, 2022. We started with an A1C greater than 9% of 25%. And then we ended down at 20%. So we actually met our target for this intervention. And then to address the racial and ethnic disparities in diabetes A1C control, we use standardized processes, provider patient engagement, we address non-medical health related social needs, and we address the impact of racism on care. And we have a whole strategy kind of around all of those elements. And our goal here was to reduce A1C by 20% from 23.9 to 19.1 was the goal for our Equity Smart Aim. And I led this Equity Smart Aim. And so within this, we created a lot of deliverables for practices around the state. Here are some of the examples of those deliverables. And you'll have the slides afterwards. You can scan any of those and it'll take you straight to the deliverable, whether it was around social determinants, social needs, how to use that, as well as addressing racism to achieve equity in healthcare. So what did we see here? What we saw was we started with an A1C of 23.9%, greater than 9%. We went down to 22.4 in year one. We got down to 18.7 in year two. So we hit our equity target as well as our overall target. First paper is published in American Journal of Public Health, and we're writing this paper up now. I also led another statewide project on blood pressure control called Achieving Cardiovascular Equity. And here are all the partners from that project. And so what was our goal here? We wanted to identify patients with undiagnosed hypertension, improve management, and address social determinants of health among this patient population. We did this through having a clinical change package. We had QI coaching, all the different pieces there. We engaged the practices in data feedback. We established referral networks. And some of the benefits included, for the practices to really try to improve patient outcomes, them getting that data feedback, and then potential to improve some of the CMS and National Quality Forum outcomes as well. And you all know here that leads to more payment, right? Which payment is critical for practices. And so at baseline, we had a blood pressure control of about 74.9%. At baseline, you see that this was also throughout the pandemic. So everyone knows the challenges around measurement of blood pressure, getting people into practices, et cetera. But even with that, during the implementation, our center line went up to 78.2%. So we had about a 3% absolute improvement. But one of the things we also saw was post-implementation, it dropped down to 76%. So what does that mean? Sustainability of many of the efforts is really key. And that's something that we're working on right now in a new grant that just got funded. What about hypertension control in Black patients? 9 of the 11 sites had improvements in hypertension control in their Black patients. And then we close the gap in hypertension control? Well, you can see here that 7 of the sites closed the gap in hypertension control. And it's been very interesting working with the other 4 sites that didn't to try to determine why. And we can talk about that maybe a little bit in the question and answer session. So within these models, we use the Plan, Do, Study, Act, or PDSA cycles, where we co-design interventions that target inequities, implement the plan, reassess the inequities, and then implement widely or co-develop a new plan. And within this, accurate assessment, disaggregating data, evaluating data, and measuring inequities are all critical to the work that we do in the QI realm. So what about health system to community interventions? So we have 3 interventions that I'll talk about today: Exercise is Medicine, Link, and Achieve, and as well as Black Impact. Oh, I'm sorry, I'll talk about Black Impact next. So Exercise is Medicine. These are the folks that work on Exercise is Medicine every day. Alan Summer leads our Exercise is Medicine program. I think someone in the back knows Alan Summer pretty well. Danya Namadi is a behavioral change expert that joined the group about 3 months ago, and she's doing some very interesting work. And then Guy and Sonia do all the stats for Exercise is Medicine. So why is Exercise is Medicine important? Well, here's Columbus, and here's our, blue is worse, and yellow is better. And this is the rates for diabetes, coronary heart disease, hypertension, stroke, and obesity. And you can see that all the areas that we have high rates of these chronic diseases, we also have high rates of physical inactivity, right? And so we have to advance physical activity. When we look at the physical activity guidelines in Central Ohio, what we know is that individuals who make more than $75,000 a year, about 31% or so are physically active. When we look at individuals less than $15,000 a year, you're down to 15%, right? Also, when you look at educational attainment, college graduates, 26, 27%. When you look at high school diplomas or less than high school, you're talking about rates kind of far less than that in our county. And then we queried individuals in the community to get some community-based perspectives on physical activity. And so when I think of health, I think of hospitals, like a nearby hospital, right? So when you think about health, you think about a hospital. It's, very, very interesting, right? That's an interesting comment. Gym memberships are expensive. Want to join a gym? Well, some of them aren't expensive, I guess, but a lot of them are expensive. We need more community centers. That would be like on a sliding scale. I think they don't advertise it, maybe purposefully, But then that kind of hinders a lot of people who don't have the funds to do stuff like that. I also think there's a lot of information that the city doesn't necessarily put out that's available out there. So we were talking about trust in our communities. You see, we have some gaps in trust in Columbus, right? And we're trying to improve those gaps over time. And so this is exercise in medicine. It starts with a physician referral. Any physician in our system can put in exercise and it comes right out to us, okay? Referral exercise medicine program. We have 9 sites throughout Columbus that individuals can go to. And I'll talk specifically about 2 of the sites that I lead, one at a recreation and park center and one at a YMCA. So these are where individuals live. And that's in a historically marginalized community in Columbus. It starts with 2 weeks with a personal trainer, and then weeks 3 through 11 are group-based physical activity. And then we do assessments at 6 months, and then again at 12 months. Our primary objective is increases in physical activity. And so what we've shown is that exercise increases by about 64 minutes per week in the program. Mental and physical quality of life improves, weight decreases, waist circumference, blood pressure decreases, depressive symptoms, and perceived stress. And I will say that some of the mental health outcomes are even greater than some of those kind of classical biometric outcomes in the program. Well, you may say, well, what about at your community sites versus some of your internal sites? Our community sites on the left here start with a, get great physical activity, really essentially the same as we get internally. And then when we go to like depressive symptoms, you can see our community sites in the triangle there start with higher levels of depressive symptoms, drop more than our internal sites or some of our suburban sites. But then what you see with that triangle, I think once again, very, very important, is that after folks are out of the program, those depressive symptoms start going back up. And so how do we limit some of that over time? And so that's some of the sustainability work that we're doing right now. You also may be thinking, well, what about by insurance status, right? And we have, group, Medicaid, Medicare, OSU health plans, self-paid and private. And you can see that we get increases really irrespective of insurance plans. Doesn't matter if you have Medicaid or private insurance. And then we see our depressive symptoms really get declines for everybody. But most notably, looking at that square, that's our Medicaid population. And they have like literally the greatest decline in depressive symptoms. But then you see they start to pop back up after the program ends. And so that's something that we're working on right now. And so a couple of additions to exercises medicine. We have a grant now from Google, where we're looking at the feasibility and efficacy of wearable technology in exercises medicine. And we're using Fitbit technology with Google. And then we have another grant from Smart Columbus, where at our community sites in the historically marginalized community, we're using Garmins. We're using 100 Garmins in that community and looking at, do we get greater changes in physical activity and some of the health outcomes when individuals utilize a Garmin versus not. So when I come back in a couple of years, I can tell you all about the results of those 2 studies. And if you want to learn more about these collaborative-based care models with diabetes, self-management, education, and support, as well as with exercises medicine, we did this NIH, NIDDK video blog, where we really spent like an hour talking about how we set up kind of all these programs and how we utilize them. So next is the LINK program, linking education, produce provision, and community referrals to improve diabetes care. This LINK program has 3 big components. It has a component of cooking matters for diabetes, which I'm going to talk about. That's diabetes and culinary education. It has a second component of that Pathways Community Hub model, where we are really working with individuals on addressing their social needs. And that is a third component of providing fresh fruits and vegetables on a weekly basis through our Central Ohio pantries, our food banks around the Metro Columbus. These are the folks that work on the project. I said diabetes and culinary education. At the bottom left is Jenny Schroeds, who leads that class, along with 2 chefs, Chef Cam and Chef Mike. And they're with folks every Tuesday for 2 hours, at one of our community-based sites. And so the Cooking Matters for Diabetes component was all Jenny's idea. And she led a great program, 6 weekly 2-hour sessions, an interactive grocery store tour, hands-on cooking demonstration, and then you got that diabetes self-management, education, and support, as well as some food provision. And what we showed in a pilot study that was published in the Academy of Nutrition and Dietetics was that we were able to increase general diet scores, health-related quality of life, vegetable consumption, diabetes self-management, physical activity, and then we had a trend towards a reduction in A1C in the pilot project. The Mid-Ohio Pharmacy I mentioned this is where folks are getting produce on a weekly basis, right? In Ohio, at least in the Central Ohio, most individuals can only visit the pantry once a month. But in our program, they can visit once a week. And we don't tell them this, they actually can visit more than that. I learned that recently because we have some people going 2 and 3 times a week. They actually don't limit it for our program, which is really great. And so what we see in our health system-based work on this, because this is throughout our health system, is that there are greater A1C reductions in uncontrolled diabetes and individuals with food insecurity that participate in the program versus don't, right? And so we you're talking about pragmatic, Greg, we kind of put that pragmatically into a research project. And so at this point, we had, 3 months ago, we had 95 individuals in the study. The average age is about 56 years, 75% women, 82% Black or African American, 2% Hispanic or Latino. The Hispanic or Latino target is very similar to the city of Columbus. About 32% are employed, 32% are disabled, 13% looking for work, 20% retired, and our average A1C at baseline is 9.4%. And so we are just now about halfway through year 2 of this project, of a 5-year project. But I'll say that even in the qualitative components of this project, participants are loving the program, and they particularly love the Cooking Matters for Diabetes. That's the piece that people keep coming back to. Like, we love engaging with the chefs and the diabetes education specialists. A third project from this kind of health system community innovation piece is Achieve, where this is achieving and maintaining euglycemia during pregnancy for Medicaid enrolled patients with type 2 diabetes through technology and coaching. So this really brings together 2 important components for pregnant people. The first is that many pregnant people feel unheard, right? We hear that over and over, whether it's Serena Williams saying that during her pregnancy, she's got all the money in the world, much more money than I'll ever have, right? But she still said, what did she say? I felt unheard, right? And she, as many of you know, she had a number of pregnancy complications related to that. And so there's the patient-reported outcomes where they can communicate through an app every day, right? The second part is that they get a continuous glucose monitor. And continuous glucose monitors are newer in pregnancy. Just the CGM-7 just got approved for pregnancy utilization. And so there's not a lot of data on CGMs in pregnancy. So we're combining both of those things together into an mHealth app that feeds to a provider dashboard with a community health worker, a diabetes nurse, a endocrinologist, as well as an OBGYN. And so we're monitoring that dashboard every day. And in this project, we use many components of this kind of user-centered design, where we got design and intervention that's really grounded in a conceptual framework, hybrid implementation study design, multi-component intervention, and most importantly, we used a model where every member of the team gave input. So the community health workers came and gave input on the app and how it works, as well as the dashboard. The patients, we had Medicaid patients come in, give us input. And in each phase, the alpha phase, the beta phase of testing, all the different phases, all these folks are giving input into the model. So the whole first year of the grant was just designing the different pieces with the stakeholders. And then we start recruitment for that grant in 2 months. So we'll get patients in then. The last piece I'll talk about is community-based participatory research. And so I'm going to focus on the Black Impact project for this. And this is part of the strategically focused research network that VCU and Wake Forest are a part of as well. And so we start with this pilot called Black Impact 100. And you can see all the partners, over 10 partners involved in this project in Central Ohio. Why Black men? Well, Black men have the shortest life expectancy of any race sex group in the United States at 68 years. And you can see the numbers for other race and sex groups. And when we look at Life's Essential 8, I already told you earlier that Black men have the lowest levels of Life's Essential 8, 63 points versus you see the numbers for other groups on the slide. And we know when we think about Life's Essential 8 that there are multiple times critical times in life, right, where we can think about maintaining and improving life's essential aid. It really starts pregnancy and in utero, having healthy mothers, right, have healthy babies who have healthier long-term outcomes, early childhood, adolescence, early adulthood, middle age, and older age. In this study, we work with individuals at early adulthood, middle age, and older age. Some of the work that we've done, though, to support this, I work with Robin Ortiz, one of my mentees at NYU, and she's been looking at some of those early life experiences. And she showed very clearly that adverse childhood events in an adverse childhood family environment lead to lower cardiovascular health scores 30 and 40 years later, right? 30 and 40 years later. We have data from Cardia that we use for this work. So people are in their 40s and 50s, and when we look back at those early ACE scores, you know, there's an impact. Child abuse, when people experience child abuse, it impacts cardiovascular health 30 and 40 years later. And then caregiver warmth actually modulates this. So the more caregiver warmth that you have, the higher your cardiovascular health scores, right? And so that childhood component, I just like to mention, is really critical. And some of the work, I know I'm not talking about some of our T2, T1, and T0 work, but some of the rationale for some of this is that we've seen changes in cortisol based on early childhood events 30 and 40 years later. So we're looking at salivary cortisols across the day here, and people have a flatter cortisol profile, which is associated with cardiovascular events 30 and 40 years later. And interesting enough, it is also impacted by caregiver warmth. The more caregiver warmth you had, the more dynamicity you have to your cortisol curve 30 and 40 years later. Some of the other components that led us towards Black impact was thinking about socioeconomic status. You know, socioeconomic status is always viewed as one of these things. If we can improve that, we can improve disparities, you know, across, right? And what we see here is when we look at socioeconomic status, and I'll use the example of high school or less, some college or more, you can see that scores for life essential aid go from about 60 to 65 up to 75 in non-Hispanic white populations. But when you look at non-Hispanic Black populations, they go from 55 to 60 to 65, 66, right? So you don't get those as great a jumps in non-Hispanic Black populations based on socioeconomic status as you do in non-Hispanic white populations. And the same thing is shown for income to poverty line, as well as same thing shown in other minoritized groups in the United States. And we know this is critical because work we've done is shown, and work of others, that if you have one cardiometabolic challenge, let's say that you have diabetes or stroke or CHD, you know, your risk of coronary heart disease mortality goes up, right? It's those in the yellow if you have one. But if you have two, diabetes and stroke or CHD and stroke, it really starts to increase. And then when you put all three of them together, diabetes, CHD, and stroke, your coronary heart disease mortality rates, you know, you're talking about a hazard ratio of 13 versus someone who has no cardiometabolic disease with a hazard ratio of 1, right? And so as these cardiometabolic diseases become comorbid, you have even more coronary heart disease mortality. And so with all that in mind, we designed this Black Impact Project where we work with the African American Male Wellness Agency. We do health screenings at these big community health events. We look for people with less than 4 ideal metrics. We work with Black Impact health coaches and community health workers, and Black Impact is founded in the Diabetes Prevention Program and the AHA Check Chain Control Blood Pressure Program, form the curriculum, as well as using community-based participatory research principles. The men suggested 6 sessions for the program as well. And so it also engages on mental health, financial wellness, a grocery store tour, some additional elements in the project. And that's all part of the community-based lifestyle intervention. We also have community health workers to address social needs through that Pathways Community Hub model. We talk about engagement with primary care, and we actually have linkages to primary care providers for those who don't have a primary care doc. And then we engage on the importance of clinical trial diversity and clinical research. So in the pilot for this project with 74 men, we show reductions in BMI, weight, glucose, cholesterol, improvements in diet. And when you put all that together in the Life Simple 7 paradigm, there was a 19% lower risk of mortality just over those 6 months. And we had improvements in Life Simple 7 scores in that project. We've also published on the importance of virtual community engagement, the role of social support, addressing non-medical health-related social needs, which we had about a 50% decrease in social needs in the project, as well as the improvements that we saw in mental health. We were able to present this at the 2022 AHA Scientific Sessions. What was great, it was virtual. So the men actually joined us for the presentation in the room. Talk about disseminating the science back to participants. That's exactly what we were doing. In addition, though, we were also thinking at the same time we were running that clinical intervention, we were also doing work to think about how does Life Simple 7 impact aldosterone? And what we saw was that individuals who had higher levels of aldosterone in green there had about a 33% lower, higher levels of Life Simple 7 had a 33% lower aldosterone level. So once again, these connections between research as well as some of those more basic and translational components. We saw that, using data from the Jackson Heart study, when we looked at people with 3+ ideal metrics versus 0 to 2 ideal metrics, those folks with 3+ had a 45% lower risk of coronary heart disease, stroke, and heart failure, in termed incident cardiovascular disease. We found that 5% of that was mediated by serum aldosterone. We then looked at the relationship between aldosterone and cardiovascular outcomes. And we showed that the relationship between aldosterone and cardiovascular outcomes was mediated by systolic blood pressure and fasting plasma glucose, right? So these relationships between, not only Life's Essential 8, but some of those biological components as well. And that has really led us towards Black impact, the mechanisms underlying psychosocial stress reduction in a cardiovascular health intervention, where we're able to, in A1, do Black impact, this time in 430 men over the course of the next 3 years, but also in AIM-2, really start to tease out some of those interpersonal and individual components that are leading to improvements. One of the things that we see in Black impact is this idea of camaraderie and team, right? And how does that build out improvements in cardiovascular health? So we have qualitative components that are led by Dr. Tamaya Nolan to really disaggregate that and understand that. And then in AIM-3, we're thinking a lot about underneath the skin, right? What is driving Black impact underneath the skin? So we're looking at hair cortisol dysregulation, we're looking at inflammation in the blood, and we're looking at the pro-inflammatory microbiome. And if anybody had told me how challenging it was to collect all that a year and a half ago, I would have really appreciated it, but we did it. So same setup. This time we're looking at Life's Essential 8 scores less than 80, but really the same setup as the pilot intervention. And so we screened men out at the walk this year, which was a lot of fun. 30,000 people attend the walk. We screened 1,300 individuals that day on the full Life's Essential 8, 1,300 Black men that day, full Life's Essential 8. We did sessions in the community. That's John Gregory, the founder of the African American Male Wellness Agency, where we talked about the program. We had our clinical research coordinators out to sign consents and everything with the men. And now the project is ongoing. So we're inside sometimes, we're outside sometimes. It's 45 minutes of a health coach. All the health coaches are nurse practitioners or docs, kind of delivering that diabetes prevention program intervention. And then 45 minutes with a personal trainer doing kind of group-based physical activity every week. They check in with their weights every week. It's a blast. It really is a blast. And so on the first 87, we have 104 men in the project. I have data from the first 87. Average age is 53 years. You can see that about 58% are college grads, 17% less than or equal to high school. Working status, about 81% are employed, 7% looking for work, 16% retired. You see the average BMI is 34, blood pressure 138/88, as well as they sleep about 6.2 hours per night. That 7 to 9 hours a night is not happening at all. A1C average is 6.2%, and the Life's Essential 8 score was 60.5 in our baseline preliminary data. And to make this happen, it takes big teams. This is the team of folks that is working on Black impact. And really what's great about it is everybody's pulling their weight. And in the bottom right corner, those are all the partners who are out. So for instance, just last night, they were calling me, the American Heart Association was out on site talking about blood pressure, right? We're talking about how to correctly measure your blood pressure, et cetera. Because week 5 is a whole blood pressure week for the health education. So in the last couple of minutes here, so we have plenty of time for questions. I'd like to say that I'm the co-founder, or actually the founder and then now medical director of the OSU Wexner Medical Center Healthy Community Center. This is in a marginalized community in Columbus. And the goal of this center is really around nutrition and wellness. Okay, so we have a healthy retail cafe. We have a demonstration kitchen for teaching cooking. We have community spaces, and we have an innovation kind of business incubator hub. One of the things, we did 8 community sessions to co-develop this with the community. And so like I'm one of the founders and the community is the other founder, which is like really cool, right? But one of the things that I'll say is that business incubation is a big part of this piece as well, because the community said we need jobs, we need businesses, we need to develop wealth. And so the retail cafe is actually run by a community partner. And in the back where we have a wellness space, we have like yoga practitioners, et cetera, who are starting up their yoga businesses within the building as well. And so if you want to learn more about a lot of this work, OSU did a story called A Prescription for Community Health in all the work that we're trying to do to tackle the disparities that we see in Columbus and really advance health equity. In the last 1 minute here, I also work on a lot of guidelines. This was the Comprehensive Management of Cardiovascular Risk Factors for Adults with Type 2 Diabetes. And one of the things you see is, if I'm going to lead a guideline, health equity across population is going to be at the top of the guideline, right? It's really, really critical. Social determinants of health were a huge component of it. We've got the screening, lipids, blood pressure, lifestyle, glycemic management, anti-thrombotic. It's all in there. It's all in there for sure. But we really did have an additional focus on those social determinants and the health equity piece. And then I was really honored to participate in this cardiovascular kidney metabolic health guideline led by Chiati and Dumile and Janani Ragaswamy. In this was a big focus of the most recent American Heart Association scientific sessions, where we think about, diseases from stage 0 to stage 4 of this cardiovascular kidney metabolic health and this patient-centered implementation focus. So to dive in this a little bit more detail, stage 0 is no risk factors. That's where we want to keep people, right? We want everyone to shift towards the left and be on the no risk factors, focusing on life's essential 8. Stage 1 is excess dysfunctional adipose tissue. And this is where we think a lot of the challenges around cardiometabolic disease come from. That's that initial piece, a little bit of extra weight in the tummy. And how do we prevent or better treat that? To prevent people to going to stage 2, which is those metabolic risk factors and CKD. So, people can have any of those and be considered stage 2, hypertension, hypertriglyceridemia, metabolic syndrome, type 2 diabetes, or moderate to high risk CKD. So any of those are put you in that stage 2. Stage 3 is subclinical cardiovascular disease and kind of this cardiovascular kidney metabolic health syndrome. And then stage 4 is my grandmother, right? Clutching her chest, going to the hospital, right? And that's what we all want to prevent. We want to prevent all of our loved ones, all of our community members from needing us. I know y'all love the Pauley Heart Center, right? But I'm sure you'd be very happy if there were less cardiovascular events, right, in the community, right? Greg might have to find some money, you got to get some more donors or something, but we all want kind of less cardiovascular events. And within that, supporting healthy lifestyles in communities is critical. And then this component of interdisciplinary care, which is really interesting. And I gave the example last night that, we're trying to, different pieces around interdisciplinary care at Ohio State. And one of the biggest challenges is things like, if I want to prescribe a PCSK9 inhibitor, the people who do the prior auth in my department for diabetes, they don't know anything about how to get that approved, right? Whereas in the lipid clinic, when they want to do a prior auth for a diabetes med, their prior auth folks don't know how to get that approved, whereas mine are very, very good at that, right? So there's these little issues, right, that when we think about interdisciplinary care and how we're going to improve those over time. So with that, I think we talked about epidemiology, quality improvement, health system community interventions, community-based participatory research in right about 45 minutes, and the importance of these academic, community, government, industry partnerships. We talked about kind of at least the T2 to T4 kind of components of the translational science paradigm. And in conclusion, advancing equity in cardiometabolic disease really takes all of us in many ways. And we really believe that academic, community, government, industry partnerships are key. And on the right side of this, there's opportunity across, right? Across all the partners, right? Just like you have your state house right here. There's opportunities at the state house to work to improve cardiometabolic disease. And so that's our picture in Ohio of it takes all of us to do this work together. Thank you. Thank you so much for your time. And I'll end with the code for CME credit.
Thank you, Dr. Joseph, for that great lecture. And thank you also for the very impactful work that you're doing over in Columbus. It's very inspiring. So if anyone has any question here, I don't know if there are any questions on the Zoom call.
Got a question, Josh?
Okay.
You know, so much of the healthcare system today worldwide is reactive. Like you've had your stroke and what do we do? And a lot of the financial resources, I would venture to say 95% are reactive. You're being proactive. What are the biggest challenges you see moving forward, either federal level, state level, society level, in terms of AHA, ACC, and community level to move more towards proactive and preventive that we all need to work on together?
Yeah, so great question. So the question, just in case people in the audience can't hear, is, you know, we spend a lot of money on reactive care, right? Sick care, et cetera. How do we move towards more health-based paradigms? And what is the role of all the partners in doing that? And so, you know, maybe just using the example of one of the partners to answer that, you know, I spend a lot of time with government, right? And, you know, government is very good at fixing problems or attempting to fix problems, but maybe struggles a little bit more on the preventing problem side, right? And so one of the biggest challenges there is that sometimes we were just having this conversation, sometimes the solutions that you put in place for something, when we think about prevention, take time, right? So you have one administration that comes in, they have 4 years or 8 years, right? And you say, you know, we're going to put in all these trails and active transportation. Well, the benefit from that, Greg, as you know, is going to come 10, 15, 20 years later, right? And so you have to convince these folks to think about 10, 15, 20 years later, but then convince them around what are the process outcomes that they can show wins for, because everybody wants a win on the front page of the paper. So what are those process outcomes that you can show wins for along the way? And then long-term, what are those health outcomes that they'll see? But it might not be in their administration, right? It might be in their bibliography 25 years from now, right? Like that, you know, this mayor really changed the trajectory of health, or this governor changed the trajectory of health. And so I think one of the challenges is to get people to see that vision, right? Then a second piece of that is how do you invest in that vision, right? Because a dollar from one place is taking a dollar from someplace else, right? And so if you take in, you know, if it sounds really good to put more money towards prevention, but what money on the quote unquote treatment side are you going to utilize to do that? Or is it all going to be private philanthropy dollars? Or so what are the creative ways in which to put the dollars together to do that work? And that's where for instance, the CARES dollars are really helpful, right? Because it was a lot of money and it had to be spent, right? But then the next part of that is you got to get all the people in the room to think about how to appropriately spend some of those care dollars in programming that will actually have a benefit, and not in something that says like, oh, hey, well, we're doing this to be doing it, right? And so I think in all of those different stakeholders that you see, you have to have this huge and dynamic conversation to boil it down to these are the components that can really, really work, right? And what I'm learning is that leadership of those conversations, not that you lead projects, but leadership of that actual conversation is something that we've never actually built out really as a skill set in public health and healthcare, et cetera, et cetera. And so even leadership of that conversation is something that we're working on. What are the best practices around that, right? As we think about best practices around building these academic, community, government, industry partnerships. So those are some of my thoughts to your question.
It's a wonderful talk. Thank you so much. My name is Aditi. I'm a first-year cardiology fellow.
Congratulations.
Thank you.
Hope you're enjoying it.
I'm enjoying it so far. So I wanted you to expand on a couple of points that you touched on during your talk in regards to sustainability and longevity of some of your work. Because, for example, some of the behavioral economics research from Penn, from University of Cincinnati that was presented in ACC in 2022 is that we have these really intense programs and processes for up to even a period of 6 months, but then the sustainability of it long term is challenging and often gets diluted. For example, Biggest Loser, they have found that after that intense intervention goes away, it's not sustainable over 2-3 years even. So I would love to hear, you had mentioned a couple of initiatives on that.
Critical, right? Sustainability is critical. And so in many of the interventions, you probably heard the pragmatic pieces, right? Like diabetes support and education, already paid for. The food pharmacy program that we have, already paid for, right? The community health worker, already paid for, right? So many of the interventions that we're doing, we're really building in sustainability from the beginning, so that once the project's over, and there's some research elements that require other people, right? But from the programmatic aspect, it really doesn't. So let me use the example of Black Impact. We've got all these people up here, right, to run the Black Impact intervention from a study perspective. But in order to run this from a programmatic perspective, you need 3 people. You need the health coach, you need the personal trainer, and you need someone, a coordinator, right? So you go from, I don't even know how many people up here, to literally 3 people. It's performed at recreation and park sites, totally free, right? The materials, diabetes prevention program, all that kind of stuff, totally free, right? All the other components are totally free. What we've done with the health coach is that we have a volunteer program at Ohio State. So these are docs and nurse practitioners who are volunteering their time. And the way that I spend this is 1 hour per week for 24 hours. And so, you know what that is, that's 24 hours, right? 1 hour per week for 24 weeks, so it's 24 hours. So I say, will you give 1 day for your community? Right? Will you give 1 day for your community? And who's going to say, no, I'm not going to give 1 day for the community, right? And so really from the beginning, we thought about, research projects are really important, but how do we build this out so that once we show, okay, the research project is successful, we can immediately go to programmatic programs, which to me actually will be much easier, right? Where we can just run groups, people like, hey, it starts on Wednesday, October 5th, and it's going to go to, April 24th, you come once a week, and we don't have to worry about all this collection and this and that and all blah, blah. We can just run the program. And so that's kind of how we think about the sustainability element of it. In our pilot project, we utilize some sustainability elements by building out some additional opportunities within the African American Male Wellness Agency. So they have some Real Men, Real Talk, they have some physical activity partnerships, et cetera. So many of our participants started doing those. And I will say that this year at the walk, we saw many of our past participants back, and they are doing incredibly well. I was just blown away. We've had transformations that just really blew me away. And then there's the other pieces of the project where, for instance, there was a gentleman who came to the project, didn't have a primary care doctor, was having urinary hesitancy, right? And so for me, in my mind, I'm like, oh, does he have an enlarged prostate, et cetera? But, when he came out and he said that, to the men in his group, the men say, oh man, you may have an enlarged prostate. I didn't have to, because I was a health coach. I was a health coach in the initial Black Impact pilot. I didn't have to say anything. And then so they said, well, you got to get checked out, and you're going to get a PSA. There was 3 guys there who were prostate cancer survivors. You're going to get a PSA. So he goes, gets PSA, he's elevated, right? It comes back the next week. Hey man, it was elevated? You're going to get a biopsy. It's okay though, you got to get it. Go get the biopsy. Let us know, is it in the prostate or did it spread outside? These are men in the study talking to them through this, right? Long story short, they coached him all the way through his treatment. He ended up having prostate cancer. It was in the capsule. coached him all the way through his treatment. He came to the last session and he had a urinary bag. He's like, I'm sorry, Dr. Joseph, that I had this urinary bag. I can't take it off from my weights though. Will that be okay? Yes, it's completely fine, right? And then we just saw him at the walk a couple months ago. He's out there running in the 5K, right? And so the men in the project, the first part, are doing just incredibly well. And so that's that other part of sustainability. How are people doing kind of over time as well? Good.
I have a question.
Yeah.
Okay, so we've long known about adiposity and its interplay with cardiovascular disease. And it's good we start with lifestyle medications and then we go to maybe bariatric surgery. Do you think this is more of like a continuum, or it's time we start like integrating them for individual patients? But because we know more often than not the lifestyle interventions, and yeah, when you have like programs like this where it's hands-on, you see outcomes, but in real life, you can give them months, they come back, weight is still up. But I don't tend to see us referring people so often for like bigger things like bariatric surgery. And even when you want to do GLP-1s, then you have to go around insurance and you have to go around things. I'm just curious to know what you think about.
Yeah, great question. And so, that integration, is where we think is key. That's why I really wanted to participate in that CKMH guideline, because that's really where we're pushing in that guideline is that, when people have dysfunctional adiposity, you got to do something about it, right? It can't just be like, oh, you need to lose some weight. Like you have to actually if you want to prevent the whole other progression, we just saw the big trial at the American Heart Association, right? Folks who had a cardiovascular event, had obesity, took a GLP-1 reduction, 20% reduction or so in cardiovascular events with a GLP-1, right? And people without diabetes, right? And so, I think the push in that guideline is that we got to do something about it. The way that we're going about that is, in addition to that guideline, there's also a prediction calculator. So now you'll be able to use this prediction tool to then look at cardiovascular kidney metabolic health, not only over 10 years, but also over 30 years, right? Which is really important for younger individuals, because as you know, you got a 30 or 35-year-old in the office and you use the pool cohort equation, their score is going to come out low, right? I mean, it just is because their age, right? Age is the preeminent risk factor for cardiovascular disease. And so now we built in, and this was led by Sadia Khan, as well as Joe Koresh. We have this great tool. And so the online calculators should be coming out. We keep going back and forth about exactly what it'll come out, but hopefully over the next 2 or 3 weeks. And you'll be able to use that in the office. And we're hoping that that really pushes people towards thinking about, okay, one, what are the medications that can be used in it? But important to say that all the medications, except for the most recent trial, were on top of lifestyle behavioral therapy. The most recent trial actually didn't have a lot of lifestyle therapy, which was what's really nice about it, to your point. And so, how do you use those? But then also, how do you use, bariatric surgery and sleeves, et cetera? But that will also take an expansion on our side, on the healthcare side, of thinking about, prescribing for GLP-1 agonists and the prior authorizations and those pieces, as well as expanding some of our bariatric surgery work as well, because, the rates of obesity in this country are large, not to.
And do you have any pills to share around how to go around like getting insurance approval for the GLPs? Because we know the
let's
work, right?
about that. I don't want that to be recorded, Well, good.
Okay.
I think it's 7:33 or 8:33. And so definitely want to respect everyone's time. But I just want to say thank you to Greg and thank you to the family that provides support for this great event, for the opportunity to come and engage. It really is incredible. You guys do a lot of great work here. Tamaya Nolan is a good friend of mine, and she knew much more about VCU than I did. She kind of ran me through. I was like, oh, this is really, really, really incredible. So just congratulations on all the great work that you're doing here, and look forward to future collaborations in the future through the SFR.
Yeah. Thank you.